Our quality improvement project evaluated the feasibility of implementing the Rapid Assessment of Dementia Risk, also known as RADAR, screening tool in a rural family medicine resident clinic to improve early detection of cognitive impairment. As busy primary care clinics, cognitive assessments are performed with less consistency than other preventative care services, largely due to time constraints associated with traditional tools, despite the significant impact of dementia on patient morbidity, mortality, quality of life, and caregiver burden. RADAR, a brief under 5-minute screening tool recommended by an interdisciplinary geriatric summit, was selected as a potential solution for integration into routine care. The study was conducted over a 2-month period. Patients aged 65 and older who were empaneled to resident providers were included, while those with a known diagnosis of dementia were excluded. A total of 86 patients were screened. Screening completion was measured against the total eligible population seen during the study period, with the goal of screening over 50% of eligible patients. Patients were stratified into low, moderate, and high-risk categories based on RADAR scores. The majority of patients, about 91%, were classified as low risk, with a small proportion identified as moderate or high risk. Key limitations we noted included a short study period, workflow learning curve that limited screening volume, and some loss of data due to misplacement of forms. So although we did not achieve the goal of screening more than 50% of eligible patients, we did find that RADAR is a feasible tool for integration into a busy primary care workflow. RADAR shows promise as a practical, efficient screening tool that fills an important gap in care. It isn't meant to diagnose cognitive impairment today. Instead, it helps us identify who may be at higher risk for dementia in the future. From there, we can take a focused next step using established tools like the MoCA, SLUMS, or MMSE to evaluate those patients more closely. This two-step approach, quick risk screening followed by targeted diagnostic testing, offers a more efficient and practical path for primary care. Looking ahead, there are several opportunities to build on this work. We can strengthen follow-up by tracking outcomes for those already identified as moderate or high risk. Integrating RADAR into the electronic health record could help automate annual screenings and referrals, making the process seamless. We also have the chance to think long-term. By rescreening low-risk patients, we can establish a baseline and catch changes earlier. Partnering with tribal health leaders will be essential to ensure care remains culturally meaningful and accessible, especially for elders and their caregivers. And finally, expanding staff training can help us scale this effort, making screening a routine and efficient part of care. Together, these steps move us toward earlier detection, better coordination, and more equitable support for the communities we serve.